I'm a pediatric nephrologist working in Colorado, and as you know, pediatric nephrologists and pediatric cardiologists like Cal mostly deal with those children who have high blood pressure. And so the recently published, late in 2017, updated clinical practice guidelines for screening and management of high blood pressure in children and adolescents are my first topic today. I have no disclosures, and my objectives for this lecture are to summarize the AAP's new guidelines regarding hypertension, to review criteria and conditions required for accurate office blood pressure measurements, and to describe ambulatory blood pressure monitoring in a little bit more detail, knowing full well that just like some areas in the United States, the option to obtain a 24-hour blood pressure reading on a child here in Jordan is not a very common one at all. These guidelines came out in Pediatrics recently. This is the title page, and I circled two of the authors because Joseph Flynn, the first author, is the head of pediatric nephrology at Seattle Children's, so there's an example for how pediatric nephrologists are at the front line of pediatric hypertension. The second person I circled, Steve Daniels, is my boss. He's the chairman of pediatrics at the University of Colorado, at Children's Hospital Colorado. But by training, he's a pediatric cardiologist. So again, there's that interplay between nephrology and cardiology when it comes to pediatric hypertension. These guidelines are a follow-up to work that was published in 2004, so 14 years passed. They're very evidence-based. When the American Academy of Pediatrics convenes these expert panels, they have very strict guidelines what to call strong evidence, what to call not so strong evidence. You see all these levels and things. And if these experts don't have enough good evidence but still agree well on something, then they're not allowed to issue key action statements. They have to be evidence-based, but they can come up with additional consensus opinion recommendations. And so these guidelines that just came out consist of 30 KASs and 27 consensus opinion recommendations. What do these KASs look like? The first four of the 30 I've copied here, and as you can see, so blood pressure should be measured annually in children and adolescents once they're 3 years of age. That's actually a step back from past recommendations where blood pressure measurements from 3 years on up were recommended at every office visit. But in somebody who's doing well, who doesn't have certain risk criteria, now American pediatricians only have to check blood pressure once a year in a child 3 years and older, unless that child has certain risk factors, such as taking medicine to treat taking medicines known to increase blood pressure, for example, medicines for attention deficit disorder, or if there's a history of aortic arch obstruction or coarctation or some other risk factors. And then, so that's what these key action statements look like, and we're going to focus on those that are the most important, I think, that are new and that are most applicable to what general pediatricians do on a regular basis. Here's an example for these consensus opinion recommendations. Mostly they refer to updated tables in this document, in this publication. And one of the new things is that there used to be a term called pre-hypertension for children who have blood pressure readings that are above the 90th percentile for gender, height, and age, but below the 95th percentile. That no longer is a term that is allowed, pre-hypertension. It should be that what we used to call pre-hypertension should now be called elevated blood pressure. And then I don't know how many of you use these tables. They're very, very complicated because, again, they go by height percentiles, age, and gender and stuff. But as you'll see, Table 4 in this document is a nice little simplified reference table that you can put at the check-in area in your office, and everybody who takes blood pressures can easily get a feel for, does this child with the blood pressure I just took need additional attention? Is that a suspicious blood pressure or a normal blood pressure in all likelihood for this child? So once again, a couple innovations here in table form. No more prehypertension, but it's now called elevated blood pressure if it's above the 90th but below the 95th percentile. And then simplified upper limits for teenagers. The old guidelines and the old reference tables used to have 90th and 95th percentiles in some tall teenagers that were higher than what is recommended for adults by the adult blood pressure experts. So, so for anybody 13 years and older, if their blood pressure is higher than 120/80, then they either have elevated blood pressure or, depending on how much higher it is, hypertension, regardless how old they are or how tall they are, because that is aligned with upcoming adult blood pressure guidelines. The other new thing in the complicated tables is that there now is a 50th percentile, which is kind of helpful because we deal with hypertension a fair amount, and we know what's high for a certain child of a certain age and gender, and then we discuss that with the family, and the parents say, well, what's a normal blood pressure for a child like mine at that age and with that size and gender? And we can't really pick that out very quickly unless we now look at these tables where we have a 50th percentile as well as reference. So what is the average? What is the normal blood pressure for a child, for any given child? And then for the really bad blood pressures, stage 4 hypertension, the panel did the math for us and calculated whatever the 95th percentile plus 12 millimeter mercury actually is, and listed that, which is a new addition to these tables. And here's that simple table. It's all you need. Boys, girls, age in years. The height is out of there. And so this tells you at any given age what's a suspicious blood pressure that may be too high or require some follow-up and some clarification. So for starters, that's all one would need in the office on the wall where kids come in and might get their blood pressure taken. So how is blood pressure being taken? As you can see, it's a multi-step procedure that starts with the child sitting correctly, and initial blood pressures, according to these guidelines, can be taken either with an oscillometric device or with a stethoscope or by auscultation. And then the question is that initial reading above or below the 90th percentile? And then all kinds of next steps may become necessary. In a suspicious blood pressure, and a blood pressure above the 90th percentile that's taken with an oscillometric, an automated device, the next reading should be done with a stethoscope, because these automated devices can provide higher readings than the gold standard measurements with a stethoscope. And then there's all kinds of guidelines and details about cuff size and whatnot. And what was interesting, oops, wrong way. What was and you know, how do you figure out cuff size? You don't have to measure arm length in all of your patients, but if you and your office team is interested in doing a really good job about blood pressure recordings in your patients, and if you want to do some quality improvement with your team, the panel actually looked for and could not find a good video that really details how blood pressures are taken appropriately and correctly in children. So they made their own video, and this is the website. So if your clinic nurses are interested in doing a perfect job according to these guidelines in taking blood pressures in children, cuff size, stethoscope, whatever, here it is. It's very nice. It's not very long, 5 or 10 minutes, I think. And according to the panel, it's the gold standard as to how to take blood pressures in children in the 21st century. So to summarize these significant changes in the current guidelines, we talked about no longer using the term prehypertension, but using elevated blood pressure so far. Interestingly enough, these normative tables actually have slightly lower cutoff numbers now for 90th, 95th percentile, whatever. And the reason for that is that those cutoff numbers are exclusively in this version of the guidelines based on normal weight children, because the obesity epidemic, at least in the United States, has been so pervasive that prior normative values included a number of children who were obese and therefore kind of artificially elevated those cutoffs. So that has been excluded, which is why the numbers that are published now, the reference numbers, are a little bit lower than in the prior version in 2004. I mentioned and showed you that simple screening table. I also alluded to that simplified classification for adolescents, so some of them don't have higher quote-unquote normal ranges than is going to be the case in adults with upcoming adult guidelines. And as I mentioned, in a perfectly healthy child, 3 years and older, you only need to check blood pressure once a year, not at every clinic visit, so that actually scales back on the screening recommendations for most children. We talked about these KASs and this 3-year cutoff. What are the children less than 3 years of age? Who should have their blood pressures checked? Pretty self-explanatory. You know, children with an organ transplant or with kidney disease and heart disease and stuff. So there is a relatively small population of children who should not wait until they're 3 years old to have their first blood pressure checked. What about other significant changes? The recommendations on initial evaluation and management were also streamlined. We'll go into that in a moment. There are revised, updated recommendations regarding echocardiography, and I'll mention that in a little bit more detail. The panel came out very clearly with a statement saying, don't worry about getting EKGs to look for left ventricular hypertrophy. If you want to look for left ventricular hypertrophy as evidence of end organ damage in a hypertensive child, you need to get an echocardiogram because EKGs for that just aren't reliable enough. So you don't need an EKG anymore in the workup of a child with hypertension. And Cal can confirm that, but the cardiologists used to go to great lengths to discuss and disagree on what exactly is LVH as far as how it is defined by echocardiographic measurements, and that has been clarified now as well, and there are clear, unequivocal criteria for LVH by echocardiogram that I'll show you. And then again, knowing that this is not something you have access to, but the guidelines do have verbiage in them for an expanded role of 24-hour blood pressure monitoring or ambulatory blood pressure monitoring, ABPM, and I'll show you a few slides on that. Very straightforward recommendation, H&P. Well, if your child has a possible high blood pressure, you need to do a history and a physical exam that looks for a variety of things, aiming to potentially get some guidance as to is this somebody who's likely or somewhat likely to have secondary hypertension. As you know, primary hypertension, which is the most common type of hypertension in adolescents and adults, is basically hypertension for which there's no clearly identifiable or treatable cause, whereas secondary hypertension has potentially reversible and treatable causes, and oftentimes these causes have something to do with the kidneys, which is where people like I come in. And secondary hypertension, of course, is more frequent in younger children if they have hypertension. and with a greater degree of blood pressure elevation at initial presentation and evaluation. So this is just a breakdown of secondary causes of hypertension. You're probably very familiar with that. As you can see, there are some endocrine causes for hypertension in children, for secondary hypertension in children, some cardiac causes, but there's quite a chunk of conditions that have something to do with kidneys that can cause secondary hypertension in children, which is why we pediatric nephrologists have such an involvement in pediatric hypertension as well. Initial evaluation, actually, for all patients, very simple. Urine, a little bit of blood work, and renal imaging in younger children or in all children who have an abnormal urinalysis and abnormal kidney function on the laboratory workup. Everything else depends on individual clinical presentation and history and findings, and so this is how then you could potentially go into more detail. So again, echocardiogram, the panel recommends an echocardiogram to obviously assess for cardiac target organ damage, and only at the time of consideration of pharmacologic treatment of hypertension. Because if there is LVH, you might be more likely to use an agent that not just lowers blood pressure, but also has beneficial effects on LVH. It's like an ACE inhibitor. And what is LVH? Well, there it is. All the cardiologists in America now have to agree on this definition of LVH. This is an ambulatory blood pressure monitor. It's like a little Walkman that people wear on a string around the neck or clipped to their belt, and then it's connected to a blood pressure cuff. It's battery operated and has a little computer chip in it, and every 20 to 30 minutes that thing blows itself up, takes the blood pressure, records it. And once these kids have been fitted with this device and the family had got some instructions what to do when the child wants to take a shower or something, we send them on their way. They leave this thing on, including while they're asleep, because one of the big advantages of an ABPM is you know what somebody's nocturnal blood pressure is. Because nocturnal hypertension can be quite an issue. And then if these families don't live close by, they mail us the device back, and then we have a computerized readout system that generates reports. There are all kinds of recommendations as to who should get an ABPM, and as you can see, there are many situations where an ABPM is considered quite helpful these days if you have access to it. This is what these reports look like. It tells you daytime summaries and nighttime summaries, and somewhere on here it also tells you how many readings were obtained. Oh yeah, there it is. Number of readings, 42 over almost 24 hours in this case, and there are definitions for what constitutes a successful reading and stuff. For the more visually inclined of us, it also gives you a printout from Wednesday at 12 p.m. to Thursday at 9 or past 9 a.m. with all the readings, daytime, and a little lower because we're supposed to dip, nighttime. There are reference ranges, published reference ranges for all of this. So it's very nice to see what a child's blood pressure does during the day and at night. And then it comes with a detailed report that is again based on literature and based on published reference ranges. What about treatment of hypertension? The guidelines from last year actually don't have any new recommendations, which is why I'm going past that. Obviously, lifestyle changes that have to do with diet and exercise and weight control are first-line therapy, and then there always is drug therapy for hypertension. For those of you who have adolescents that are hypertensive but want to participate in sport, the guidelines are as long as these patients have blood pressure with or without treatment that's below stage 2, they should participate and can safely participate in competitive sports. So in summary, the pressure is on your patients and their families to eat and live healthy and active. on you to get accurate blood pressures and make thoughtful evaluation and referral decisions, and on us subspecialists to provide timely, helpful, and valuable consultation and management, including ABPM if available. And the system, I think, to whatever, outlaw soft drinks at school, facilitate truly universal insurance coverage, which is a big deal in the US right now. So the pressure is on all of these involved parties. Thank you very much.